So our next speaker is Wendy Patterson, a nurse practitioner from Gandangdara Health. So she's here to talk about the nurse practitioner in general practice. Historically, there has been many changes in primary healthcare nursing, not only in terms of clinical care, but also in regard to many professional and regulatory aspects. The role of the nurse practitioner in general practice is part of these clinical and professional changes. Momentum is building in terms of recognition and respect for the specialty in which we work. So Wendy's here to talk about what is the process in becoming a nurse practitioner in Australia, what does a nurse practitioner in general practice do, and how does it differ from the practice nurse, and why does the role matter and who benefits? So please welcome Wendy.
So, welcome. Thank you so much for all coming. Kay's got us all fired up about nurses stepping up, and that's exactly what I'm talking about today. So, just a little bit about myself. I actually come from a hospital-based training. I trained just up the road from Kay in Royal Prince Alfred Hospital.
That's where I did my adult.
That's right. We're all out the back fagging. So, I've worked right up through, the hospital system, then undergraduate, postgraduate now, and now into this wonderful role of the nurse practitioner. I actually think I've just hit my stride in my 50s, and I think it'd be lovely to see all the younger people in this audience actually see this as a path for them. Our specialty has so much to offer, and we really need you all to think about, and I'm thinking that the people in this group are actually the people that are in there listening to our keynote speaker and thinking, this is for me. So I want you to have a good think about it. I'm sort of the hen's teeth. There's a couple of us in the room, and I just wonder if nurse practitioners might just put their hand up. So we've got 1, 2, 3, 4. Is that right? That's just about representative of where we are in this profession. So we'll have a little slide about that in a minute. But it is something I'd love to see 50 hands go up in the room, because we need this leadership. Okay? So we'll get started, and tell me when I'm talking too long. I tend to do that. So the aim today is to detail the history of the nurse practitioner movement. To know where we're going, we've got to see where we've been. Explain the present role of the nurse practitioner in general practice. Highlight the benefits for the role of the community and the profession, and create discussion. I hope you all go out and start talking about the whole thing. You probably all remember this lady. and if you come from my era, this was our nurse, wasn't it? That was Nurse Ratchet, for anybody that doesn't know who Nurse Ratchet is. We had that sort of a nurse on the ward, and we were all very frightened of her, weren't we? She was what we called a nurse leader back in those days, because the one that was the scariest usually was making the rules, okay? Wasn't based usually in any clinical setting. It was basically who'd been there the longest and who was the scariest. It also, just seeing the faces that recognise this lady, actually indicates what age group we're talking about too. We have a lot of momentum building at the moment for some changes, and we've gone from this to where we are now. Think about that, just in the short period of time. And I thought about that when Magdalene talked about it with her. She'd gone from those very beginnings right through, how different it is for us all now. And NPs were not the first. When we think about Florence Nightingale actually was an absolute game changer in terms of what nursing did. So reading from her background, her social reforms included improving healthcare for all sections of the British society. Is that not what we're all about? Improving healthcare and advocating for better hunger relief in India, helping to abolish laws relating to prostitution that were overly harsh to women, and expanding the acceptable forms of participation in the workforce. So she made enormous changes. And I think we all need to just light that Florence, in us all. We're not quite at this level, but we are achieving some of those parallels. We're trying to access care for all. So that's basically what nurse practitioners are trying to do. So we are a choice in that healthcare professional pool. And so especially where I work in Aboriginal health, it's an access to care that often isn't there for that population, okay? And women and all that sort of thing as well. We're accessing the care, changing laws, and we're expanding the participation in the workforce. So it doesn't sound unlike what Florence did. The nurse practitioner movement originated in the United States in the 1960s, so you heard about that earlier. But it wasn't until 1991 that we sort of caught on that this might be something that we need to do. So in New South Wales, the Nurse Practitioner Committee was convened in 1991. In 1994, there were some pilot projects commenced. The outcome of the evaluation found that these nurse practitioners were feasible, safe, effective in their roles and provided quality health services, which we all know we do. In 1998, the Nurses' Amendment was changed to include the Nurse Practitioners Act. And then in 2000, our first nurse practitioners were authorised in Australia. They were Sue Dennison in rural and remote and Jane O'Connell in emergency. Whoops, gone the wrong way. Then the biggest change came in 2010. Nicola Roxon, God bless her socks, wish we still had her. She was wonderful. She made some big changes, didn't she? She brought in the plain packaging for the cigarettes. She made some great gains, and one of her things was a determination in 2010 to include collaborative agreements for nurse practitioners. Now, we will talk about collaborative agreements a little bit further on, but this gave us access to the MBS and PBS. Oh, it's a bit short. Is that better? Okay. This little chart here will just give you an idea of numbers in Australia today. We have a grand total of 1,058 in March of this year. I'm excited. I'm so excited. In New South Wales, we have, what have we got? 248, okay. And there's some PPPs, meaning there's no participating practice place. So they don't work anyway. I can't remember what the PPP is. But you can see, just like in this room, there's only a few of us. And we are almost the hen's teeth of the nursing profession. What is a nurse practitioner? So this will really just nail it down. It's a bit wordy, but just we'll read it. Is a registered nurse. And I think that's the first thing to say, that we are nurses. Our role is an extended role. So we are first and foremost, I'm a nurse right through my bones, right from the Pan Room in 1979 to here. That we have completed both advanced university study at master's degree level and extensive clinical training to expand upon the traditional role of the registered nurse. So we're talking about expanding. The nurse practitioner is a protected title, meaning that you can't call yourself a nurse practitioner unless you are. This title represents rigorous educational and professional standards. The role of the nurse practitioner includes, but is not limited to, the prescription of medicines, referral to other health professionals, and the ordering and interpreting diagnostic testing within a defined scope of practice. We'll get onto all those little names in just a little while. The endorsement process here in Australia. So this is good to get an Australian perspective because, of course, we've just heard about all those other countries, but this is what goes on in Australia. To be eligible for endorsement to be a nurse practitioner, you must hold either of the following qualifications relevant to the endorsement. An approved qualification or a qualification that the National Board considers to be substantially equivalent to master's level. So you might come at it from another level. You might have a master's or a PhD in something else, and they will consider that in the way that we're doing it. But for most of us, and probably most of us in the room, I think, we've gone at it through a master's degree in nurse practitioner. Okay, so that is now how we go about it. Depending on your qualification, then you take pathway 1 or 2. Pathway 1 is the most used one. This is a bit wordy too, sorry. I hate these screens. I always sit and go, oh. So what happens in the next bit, and just to paraphrase all of that, is that you submit a portfolio. Those in the room, that if I say the word portfolio, most nurse practitioners nearly fall on the floor because it is a long process to put your portfolio together, and it is the way that you are endorsed. So they look at your portfolio to be endorsed. So you need to be obviously currently registered. You have to have no conditions or restrictions on your registration. You have to have the equivalent of 3 years full-time experience in an advanced practice nursing role within the previous 6 years before you start to apply. Okay? The completion of the board-approved nurse practitioner program of study at a master's level, so that's your degree that you're going to do, and you need to show compliance, and this is where the portfolio comes in, is that you need to show that compliance with the national competency standards for nurse practitioner. And compliance is dependent on your CPD points as well. I could talk for hours on this, I'm sorry, it just gets really quick. Just quickly, briefly about advanced practice role, because we hear all these terms bandying around. I don't know whether everybody else hears them, you think, oh, what does it all mean? This is actually, yes, it's APRA's definition of the advanced practice role. It defines a level of nursing practice that utilises extended and expanded skills, experience and knowledge in the assessment, planning, implementation, diagnosis and evaluation of nursing care required. Notice it's nursing care, okay? So even though we use a medical model in a lot of what we do, especially when we come to prescribing, it is based in nursing care, okay? Nurses practicing the level, we've talked about that before. We might just press on. How am I going for time? Okay? Yeah, okay. I'm sure you're all thinking, how does this all fit into general practice? Because I'm assuming that the vast majority of us come from general practice. How do we actually do this when we're in essentially a small business model of healthcare delivery? So how do you start this? How do you do it? Well, I can tell you it's a little messy, just from personal experience. I think I had this spark of, I want to do this, how do I do it? I was in a really good position in a practice that I felt respected and quite autonomous in what I did. I'd done some extra education, and I went to them and said, I think I want to be a nurse practitioner. And the role just evolved, okay? So when we're talking about leading and changing and making these changes to this profession, you can't wait, I think, sometimes for things to happen by somebody else. If you feel that passion, as it was, to do something, then just give it a go, because you never know your luck. I don't know what the experience is with everybody else, but I do know I have a colleague in the room who was of a similar ilk, and it was more of a discussion that we had between ourselves that I think I want to do this, and I think we work in an area where the doctors and the people we work with will support us doing it. So take the step. So the positions are ideally created when there is an identified clinical need, service need, or a gap in the target population. So you might live in a town that I come from country New South Wales, and you might have an area of need within your town, and you just need to step up and think, how do I fill that in? How do I target that population? The role might be a new model, like a completely new job that you start, or it just might be what you do already, but you're going to expand through your skills, your new learned skills, into that role, okay? Now, there are 3 things that go along with nurse practitioner. It's called collaborative agreement, in this country, scope of practice, and formulary. So I think Madrin, she discussed a little bit about collaborative teams. Well, in Australia, to use the medical benefits scheme, we have to have a collaborative agreement. The collaborative agreement is actually your scope of practice, so you have to define it, and all of your portfolio and putting your portfolio together actually helps you create that. So it's a pain in the butt when you're doing that, but it actually makes you define what it is that you do, and you do very well, okay? So that's what you have to have in place. It's a piece of paper that basically you write it out. It's quite a long document, not a piece of paper, quite a long document which outlines what you do, what you won't do, exclusions to care, when do you escalate care to a medical professional, those sorts of things. So it's a really tight little document. That is signed by those people that you have the collaborative agreement with, and then that allows you to access, with a provider number, the MBS and the PBS. Now, to do the PBS in New South Wales, you have to have the Chief Nurse of New South Wales, not the Fed, not the Commonwealth, but of New South Wales, to approve your own formulary. Now, for us hen's teeth in the room, we've had to make up our own formulary. So we've had to sit down and think, what is it that I want to prescribe? What do I want to continue prescribing that a doctor may have ordered? So you have to sit down and think about, what's your scope of practice? For me, women's health, immunisation, all these sorts of things, I know that really well. So I feel quite comfortable to prescribe the pill, to continue some hormonal treatments, those sorts of things. So you put together all this documentation and you send it off to the chief nurse. I've since I've been doing this as a nurse practitioner, two and a bit years, I've resubmitted it 4 times because I'm ever expanding, so ever learning and ever thinking, well, there's a couple more things I actually want to do. I actually feel quite comfortable. So I'd probably have about 150 drugs on the formulary, and probably 70 of them are initiated by me, and the other half are probably things that I continue on. Okay. So I work in a general sense. I'm a generalist nurse practitioner, and I think we need to define that when we talk about. So some people are purely women's health practitioners and other people, but I'm more of a generalist because I work in a general practice and I was a general practice nurse. So I think for a lot of you, that is the trajectory that you're looking at. I can see, just thinking about a few other things, there's a lot of talk in the College of Nurse Practitioners about people coming into general practice from a specialty, perhaps cardiac, perhaps emergency, and they want to come in. They can see the benefits of being in general practice. But guys, all of us in general practice are specialists in our own area, and you know what that is. It's a huge area, and to get across it, you do have to have a lot of experience in general practice. Okay, so it's not something you just, do on the side. We are a specialty in our own right, general practice. Okay, we've done about that. I think we've covered all that. There is more. I won't go too much. I'll just tell you about the continuing professional development. As a nurse practitioner, you need 10 more points, so a total of 30 points each year, and those 10 points have to be, related to prescribing, referring, those extra duties that you have as a nurse practitioner. Recency of practice, you can't be just doing it and then wander off into the bush one day, come back 5 years later and decide to do it. And you need to have professional indemnity insurance. That's been a little path that I've just gone down now with, I've started to put in implanons and contraceptive rods, and I just wondered if I'm covered. So I did ring up and made sure that I was covered for it. So yes, they do say we are. I think because we're quite safe, nurses are quite safe, so our premiums are quite low, generally speaking. And okay, how does the nurse practitioner help? And I love these two because this is so true, isn't it? You're at work and it's busy, and then I said, the doctor will be with you in a minute. It's hilarious because he won't be, It's hilarious. They just think it's funny. And I thought, when I saw that, I thought, you're right. So what we actually do is we get people to access care, okay? So people move through the system a lot quicker. How many times have you known what exactly that patient needs? You stand there, you know what they need. They've got a UTI, you've dip-stipped it. You know that's got to be sent away. You know you're going to start them on trimethoprim. You know it. You're standing there. So why don't we own what we do? We know it. And we're very safe. And we'll probably take 10 minutes with that patient, telling them about pushing fluids and taking the Ural and, all those sorts of things that just get missed in the message when a doctor runs in 5 seconds, hands the script, and the patient wanders off. And you're sort of... So it's this owning and making a complete episode of care. Patient walks in, sees the nurse practitioner, walks out. They think it's great. It's fantastic. Okay, the nuts and bolts of the whole thing. So for me to work in general practice as a nurse practitioner, I use these item numbers. And as you can see, I'm not retiring early. So I've actually negotiated a wage package. So I think you have to get your negotiating hat on as well, because this doesn't work, especially in Aboriginal health. I'm working in an area where you could not put a co-payment on it. Should I bring up that subject? So the only thing I can say is that you do need to be in a position where you can negotiate a wage that you think is right for you. And I think we need to, as nurses, all be doing that, okay? So we all do different things, so we should be negotiating our wages. Nurse practitioners are able to perform, and I only found this out, perform certain pathology tests. I didn't know whether anybody else, the other nurse practitioners in the room, knew about that, but we can actually perform the pathology tests. I don't know what they are, but anyway, I found it out as I was doing this. But mainly we request a range of pathology items and diagnostic services. So you have a list of things, and there's a document which you can download, because I know you're all interested in this now, and it's called Eligible Nurse Practitioner Services Questions and Answers, and that's from the Department of Health. Basically, I'll give you the websites at the end. And that gives you everything you've ever wanted to know about nurse practitioners. How, provider numbers, how do you get a provider number, all these things, what tests can you order, what tests can't you order. And of course, it's all about your scope of practice. So you can't be out doing brain surgery in the tea room. Okay, there are teething problems with this, as always there will be, and being only so few of us, we don't have a lot of weight of numbers. And that's why I'm encouraging people to embrace this idea. We do need to get a few things sorted out, and these are the things that we need to get sorted out. At present, if we have somebody for wound management and we're treating them for a wound, an infected wound, and we want them to have dressings, and the vast majority of them are hobbling in and they're a repat patient, we can't prescribe anything. So it just, again, just puts a little barrier in the way. You've got to ring the doctor and you've got to sort that out down that end. Some basic imaging services are inexplicably not listed. And Jo Perks in the room here is a women's health nurse, and she'll join with me and say, why we can't order a pelvic ultrasound is beyond me. I can order a testicular ultrasound. Haven't done one of them yet. But I can't do a pelvic ultrasound. And it doesn't matter who you ask, nobody seems to be able to answer that question. Anyone got any answers? No? Okay. There's other ones too that I can't think of that we can't order. But anyway, remuneration through item numbers alone do not pay NPs enough if they're in private practice. So I've been down that path as well. I've been down that path as well with the doing my own business. I got my ABN and put myself in a room and, yep, sausages for about 3 months. So, yeah, not enough money. Just can't do it because you've got to pay for the room you're in and the services and the services of reception and things like that. And there's no procedures. So when I put an implant in as opposed to a GP, I can't charge an implant insertion item number. So that's the problem. So I take 40 minutes to put my implant on. Hope nobody's listening to that. Okay. What do we do? And, you know, we could sit here all day and talk about the differences. It's different for each NP. Okay, so you've got to understand that we work from guidelines. We don't work from a procedure. We don't work, this is what a nurse, don't open the book at page whatever, and this is what a nurse practitioner does. We work with guidelines, much the same as as a GP would. It doesn't mean that's what you have to do in every circumstance. Okay, and that's where the clinical reasoning and decision making comes into it. And it's different for every practice. So one practice might like you to do one particular thing, and you might do other things in other practices. We work autonomously. That means there is no input from the GP. Now, that's hard. That's a big thing. That's a big step. Okay, so a lot of us who work quite autonomously will still have the backdrop of being able to talk to the GP. There is always a GP I can talk to collaboratively, but I take ultimate responsibility. When I treat that person for a urinary tract infection, have I looked at the differential diagnosis? Have I looked at all the different things that this person could be presenting with? And so that comes into that critical thinking. Okay, advanced physical assessment. That's one thing I think that just sets us apart. So we will listen to someone's chest. You know, we will actually do an abdominal examination, a pelvic examination, all those sorts of things. We're just stepping it out a little bit. And it's things that you guys know. I know you do, because you've been watching GPs do it for millions of years. And collectively, we have a lot of knowledge. What we need to do, and probably in the universities, we need to get that level of examining a patient for nurses. We need to interpret the results. So if I order a full blood count, I need to be able to interpret it. I can't go running off to the doctor and say, what does this MCV thing mean? Why is that elevated? Okay, so I have to know that. And you have to take responsibility that if it's elevated and you do nothing about it, you need to take that responsibility. And to obviously prescribe medication is a whole nother ballgame. We could go on forever. And she's hoping I don't. What are the benefits? We have a nurse practitioner improves access to treatment, offers cost-effective care, targets risk populations, increases access, increases choice, and increases numbers of patients seen. You will whip through your day because there's no waiting. The nurse practitioner is there to deal with what she can deal with. Things that she can't, and there's a whole other thing about escalation of care. So I can still see a patient, bill Medicare, but escalate the care to a GP. And that's because it's out of my scope of practice. Okay? Provide outreach services in rural and remote communities. Benefits to the profession. This provides mentorship, clinical expertise to other nurses. fosters excellence in clinical care, provides career framework to those nurses wishing to remain in the clinical setting. How many of you love what you do? You love your patients. And to get on in this sort of profession, we seem to have to go into academia or to administration or something like this. But this allows us to move up without moving away from the patient. Encompasses the core principles of nursing and promotes ownership of the healthcare that we deliver. At the moment, a patient will come in and say, the doctor he's doing a great job with my wounds, he's got my infection under control, and you're thinking, damn it, I've just been in the treatment room for half an hour and I'm the one that's doing it. So, there is this perception that it is doctor-led. We need it to be nurse-led because we are the ones actually doing it, aren't we? It is solitary pursuit for us wanting to do it, so you need to be quite strong in what you do. Some GPs protect territory, income and status, and I've come across that as well. Lack of understanding, sometimes misunderstood by colleagues, both medical and nursing. I have had my harshest critics come from other nurses. Expensive postgraduate education. I actually had a scholarship from APNA many years ago, so I did the whole thing through a scholarship. So there are ways of doing it. The rewards have been your satisfaction. I'm probably going over myself here. It's a varied career path. It's promoting excellence in clinical care at a lower cost to the community. In this budgetary, is there anybody in this room that just thinks, has anyone discussed nurses in this whole budget? We're talking about co-payments and GPs all the time, and not one person has mentioned that there is nurses in the general practice. And if we all got behind nurse practitioners, there would be nurse practitioners that could offer a lot of the care. How many GPs are doing immunisations and charging the government when there's a nurse that is actually authorised, educated and competent? If Liz is in the room, I've always remembered those 3 words, educated, competent and authorised to do that in that setting. Why then is a general practitioner using the Medicare system for that? Think about it. Help GPs see more patients with more complex health needs. Okay? Let them get on with the people that are really needing to be sorted out. Earning better if you're a good negotiator. Thriving through change, which is what it's all about. The job we do as nurses in general practice can change the health outcomes for many people. To attract and retain these primary healthcare nurses in general practice, we need this career structure and this specialty in nursing. The actions we take today will change what the future will be. Don't sit there and think, it's probably a good idea. But we've all got to 70 to do it, so you've got lots of time up your sleeve. I hope you feel inspired. I hope that I can somehow make you feel what I feel. I feel like I've reached the destination, the one that you've always been hankering after. Okay? Where to start? Don't be afraid to tick outside the box when it comes to your role. Start to own what you do. Okay, step up. Know your scope of practice, but don't sell yourself short. You know these things. When you know about that UTI, you do know about it. Study, research, and extend your knowledge base. Thank you. There's some useful sites there.